Alright, so today I'll be discussing pacemakers and implantable cardioverter defibrillators, or ICDs, and their implications for exercise and exercise prescription. So to start, pacemakers and ICDs are medical devices used to manage abnormal heart rhythms, also known as arrhythmias. A pacemaker is designed to regulate slow heart rhythms called bradycardia by ensuring that the heart maintains a minimum heart rate. On the other hand, an ICD is used in more severe cases. It can detect life-threatening arrhythmias such as ventricular tachycardia or ventricular fibrillation and deliver a shock to restore a normal rhythm. Both devices are implanted under the skin, typically near the chest, and are connected to the heart through leads. These devices are especially important for individuals at risk of sudden cardiac death, making them highly relevant in clinical and exercise settings. Now, moving on to prevalence, the use of these devices has increased significantly over time. Currently, there are approximately 3 million people worldwide living with pacemakers and over 1 million individuals with ICDs. In the United States alone, more than 200,000 of these devices are implanted each year. This rise is largely due to an aging population and improvements in medical technology that allow more people with cardiovascular disease to survive and receive treatment. And implementation is higher in men compared to women. And then moving on from an epidemiological standpoint, these devices are most commonly seen in adults over the age of 65, and they are more prevalent in males than females, like I said. Patients who receive pacemakers or ICDs often have underlying cardiovascular conditions such as heart failure, coronary artery disease, or hypertension. ICDs are frequently used either for secondary prevention, meaning after a cardiac event has already occurred, or for primary prevention in individuals who are at risk for developing life-threatening arrhythmias. And then while the cardio CIED implementation has increased between 1988 and 2005, trends showed a slight decrease in overall implementation rates between 2000 and 2005, and 2012 and 2018, although CRT use is increased in that period. Now, let's talk about how these conditions affect exercise response. Individuals who have pacemakers or ICDs often experience reduced exercise capacity. One of the main reasons for this is a decrease in cardiac output during exercise. In addition, many patients experience something called chronotropic incompetence, which means their heart rate does not increase appropriately during physical activity. As a result, these individuals often have a lower VO2 max, sometimes 15 to 30% below healthy individuals. They may fatigue more quickly and have difficulty sustaining higher intensities of exercise. There are also peripheral limitations, such as reduced blood flow to working muscles, which would just further contribute to early fatigue. However, despite the limitations, exercise training has been shown to provide significant benefits. Regular aerobic exercise can improve VO2 peak by approximately 10 to 20%. And it also increases stroke volume. It improves the efficiency of oxygen use within the muscles and leads to better overall cardiovascular function. Now, let me see here. Go back. Beyond the physiological improvements, exercise also increases functional capacity, allowing patients to perform daily activities more easily. It's also been shown to reduce hospitalizations and significantly improve the quality of life. Importantly, research has demonstrated that exercise is safe for this population when properly prescribed. Looking at the research, studies consistently show that structured exercise programs lead to meaningful improvements in cardiovascular fitness without increasing the risk of adverse events. For example, individuals in exercise groups often see a 15 to 20% increase in VO2 peak, while control groups show little to no improvement. Additionally, the risk of ICD shocks occurring during supervised exercise is extremely low, typically less than 1%. Now, another important factor to consider is medication use. Many of these patients are prescribed beta blockers and antiarrhythmic medications and ACE inhibitors. Beta blockers, though, in particular, have a significant impact on exercise because they reduce heart rate and contractility, which leads to a blunted heart rate response during exercise and a lower maximal heart rate. Because of this, traditional heart rate based training zones like zone 1 and zone 2, etc., may not be accurate for these individuals. So instead, they tend to rely on ratings of perceived exertion, RPE, typically targeting a moderate intensity range of about 11 to 14 on the Borg scale. Now, looking at the case study here, we got John D., 58-year-old male who's 5'10", 210 pounds. His BMI is 30.1. Some of his medical history is ischemic cardiomyopathy, prior myocardial infarction 3 years ago, and he has an implanted ICD a year ago due to ventricular tachycardia. He also has hypertension. And he's taking a beta blocker, he's taking lisinopril, which is an ACE inhibitor, and he's taking atorvastatin, which is for high cholesterol. His resting vitals, his heart rate is 62 beats per minute, but that could be beta blocker influenced. And his blood pressure is 138 over 84. His goal is to improve cardiovascular endurance, reduce body fat and weight. He wants to lose 15 pounds and increase muscular strength and functional capacity. He also wants to improve quality of life and confidence with movement and reduce the risk of future cardiac events. So, for the exercise testing, I'm going to have him do a modified Bruce treadmill test for 9 minutes just to assess his baseline level. And for the strength test, we're going to do a submaximal lift. So we're going to do 70% of his 1 rep max for chest press and then 180 pounds on the leg press for the strength. And then moving on to flexibility for John here, we got the sit and reach test, and he scored a below average. And then his shoulder mobility is limited due to the ICD site in his upper chest. So that's that. And then here's his exercise prescription. For aerobic training, we're going to train 4 to 5 days a week at 40 to 70% of his heart rate reserve. Anything like walking, biking, or the elliptical for 30 to 45 minutes per session. And then we're going to have him lift weights for resistance training 2 to 3 times a week at a moderate intensity, so 50 to 70% of his 1 rep max at an RPE of 11 to 13 for him. Typically, we will do 1 to 3 sets, 10 to 15 reps, and 8 to 10 exercises per session. we'll do leg press, chest press, lat pull down, seated row, body weight squats, things like that. And to increase his flexibility, we're going to train 3 times a week, stretching to mild discomfort. And he's just going to focus on static stretching, stretching his hamstrings, his hips, his chest, and his shoulders. So that's what I would do for John D here with the ICD. Now, there are also several key modifications that need to be considered. One of the most important is maintaining exercise intensity below the ICD activation threshold. Usually keeping heart rate about 10 to 30 beats per minute below that limit. He should avoid contact sports just due to risk of damaging the device, as well as heavy straining or holding his breath, also known as the Valsalva maneuver. And proper warm-ups and cool-downs are essential to allow the cardiovascular system to adjust gradually, and monitoring his symptoms closely during exercise is also critical. In terms of safety, exercise should be stopped immediately if the patient experiences chest pain, dizziness, shortness of breath, or if an ICD shock occurs. And medical clearance is required to start an exercise program, and supervised exercise is often recommended, especially in the early stages. So to conclude, pacemakers and ICDs play a crucial role in managing cardiac conditions, but they also introduce unique challenges when it comes to exercise. But despite these challenges, exercise is both safe and very beneficial when properly prescribed. It'll improve cardiovascular function, enhance quality of life, and ultimately just reduce health risks. The key, I would say, is to individualize exercise programs, monitor intensity appropriately, and prioritize safety at all times. So, thank you.